thank the Congress for giving us the chance to present our RCT here. And it's my honor to give the presentation on the behalf of our leading PI, Professor Guan, and our study group. The title of our trial was Terlipressin versus norepinephrine as infusion in patients with septic shock, a multicenter randomized double-blind trial. And this article has been published on ICM on July 1st. Today, I will share with you about the following aspect. As we know, septic shock is associated high mortality and morbidity. To correct hypertension in septic shock, vasoactive drugs was one of the most important therapies. According to the guidelines of SSC, norepinephrine is still the first-line recommended vasoactive drugs to correct hypertension. Vasopressin, endogenous release peptide hormone, has emerged a choice to maintain the blood pressure in septic shock. However, in the recent studies about VASST study on New England Journal and Venus study on JAMA failed to demonstrate the vasopressin can reduce the 28-day mortality compared to the norepinephrine. However, the Venus study demonstrated the vasopressin can reduce the renal replacement therapy. As we know, vasopressin can stimulate multiple receptors, namely V1 receptor, V2 receptor, and other receptors. Terlipressin, a long-acting vasopressin analog, has a much higher affinity to the V1 receptor than the others. Several small sample-size clinical studies and meta-analysis has demonstrated that terlipressin can reduce the norepinephrine requirement in septic shock. However, there was no evidence powerful enough to evaluate the effect of terlipressin on mortality, organ dysfunction, and safety in septic shock. So the aim of the current trial was to determine the efficiency and safety of terlipressin in septic shock. This trial was conducted in 21 intensive care units in 11 provinces in China between January 2013 and February 2016. A sample size of 1,000 patients was originally calculated. Consider the dropping out rate of 10%. The trial was needed to enroll 1,100 patients. Patients older than 18 years old diagnosed with septic shock during their ICU stay were included, and the septic shock was defined as the following standards. Randomization was done by the computer-generated sealed envelopes, and in order to avoid the heterogeneity of septic shock and the hospital variation as much as possible, the block randomization was used. Once the patient was included, the sealed envelope was handed over to isolated pharmacy. The nurse in the pharmacy prepared the study drugs according to the allocation written in the card in the envelopes. The study drug was colorless and transparent and cannot be identified by the appearance. So the investigator, the researchers, and the patients and their relationships were strictly marked to the assignment. Patients included were randomly assigned to receive terlipressin or norepinephrine. Terlipressin 1 milligram or 11 milligram norepinephrine was dissolved in 5% dextrose in water with a 50 milligram string. The final concentration was shown here. The study drug infusion started at 1 milligram per hour and titrated to achieve target mean MAP. The maximum study drug infusion was 8 milligram per hour. If the target MAP was not achieved at the maximum study drug infusion, an open-label norepinephrine was added. The primary outcome of of our trial was 28-day mortality, and the secondary outcome included changes in SOFA score and day 7, days alive and free of vasopressor during 28 days, and the serious adverse events. The enrollment started in January 2013. This picture showed us the participant center distributed in 11 provinces in China, and 2 planned interim analysis was conducted. In the second interim analysis, the Data and Safety Monitoring Board assessed the intention to treat on 28-day mortality, and the two-sided O'Brien-Fleming boundary was used to assess the early stopping of the trial. The observed PVLO fell within the futility region, so the the monitoring board recommended cessation of the trial. So the recruitment was stopped early at 50% enrollment in February 2016. The analysis was performed on data from an intention to treat population. So finally, 526 patients were included in the final primary analysis, 260 in terlipressin group and 266 in norepinephrine group. From these two figures, we can see the mean arterial pressure and serum lactate on the first 7 days were similar in 2 groups. And the primary outcome, 28-day mortality, was 40% in terlipressin group and 38% in norepinephrine group. There was no significant difference between 2 groups. Secondary outcomes, both terlipressin and norepinephrine can improve the SOFA score on day 7, but the improvement was similar between groups. Also, days alive and free of vasopressin were similar between groups. However, we found more serious adverse events in terlipressin group. 12.6% patients received terlipressin experienced digital ischemia, and only 1 in norepinephrine group. More diarrhea was found in terlipressin group. Also, we do some post-hoc analysis, and this data was shown in the supplement. There was no significant difference was found about other prognostic outcomes, such as days of vasopressor, days with ventilation, days with RRT, and so on. It was very interesting. We found the reduction of serum creatinine on day 5 and day 7 after randomization were more remarkable in terlipressin group. However, we failed to find terlipressin can reduce the AKI occurrence and renal replacement therapy. So, to the best of our knowledge, the current study was the largest randomized controlled double-blind multi-center study about terlipressin in septic shock. Our trial demonstrated terlipressin was effective to correct hypertension in septic shock, but it did not reduce 28-day mortality compared to norepinephrine. As we know, higher SOFA score is associated with higher mortality in sepsis, and rapid improvement of SOFA score implied lower mortality. In our studies, both terlipressin and norepinephrine improved the SOFA score on day 7 after randomization. Although a greater reduction of serum creatinine on day 5 and day 7 in terlipressin group, but we failed to demonstrate a reduction in renal replacement therapy or acute kidney injury. So, whether the protection can protect renal function needed to be further investigated. Another important result of our trial was the higher serious adverse events in terlipressin group, particularly digital ischemia. In the post-hoc analysis, we found patients with digital ischemia had higher hepatitis score, SOFA score, and dosage of vasopressor at baseline. This data implied more severe shock might produce higher risk of digital ischemia. What's more, other reasons might be responsible for the higher rate of digital ischemia. Most of our patients with digital ischemia receive terlipressin and norepinephrine at the same time. So combination of these two drugs may cause massive peripheral vasoconstriction and leading to higher risk of digital ischemia. Secondly, the dosage of terlipressin in our current trial was higher than those reported in previous studies. In conclusion, in this multicenter randomized double-blinded trial, we observed no difference in mortality between terlipressin and norepinephrine infusion in patients with septic shock. Patients in the terlipressin group had higher number of serious adverse events. The dosing regimen and safety of terlipressin infusion in septic shock need to be further investigated. Thank our team, thank all the people who contributed to the trial. We keep going. That's all my presentation. Thank you for listening.